Greetings, students, and welcome to our module on integrated care. For purposes of this module, we will be defining integrated care as the marriage between primary care medical services, which would essentially be having your family or primary care physician who you see for annual exams and routine health concerns and so forth, and counseling or behavioral health care. So let us start off with focusing or covering two reasons given in your text for the importance or the case to be made for integrating mental health and primary care services. And we'll be focusing on public mental health for most of this lecture. The first reason to integrate is that many of the consumers of public mental health services are not getting adequate physical care or medical care from primary care services. They may be getting some treatment for their mental health disorders, but they're not getting adequate treatment for their non-mental disorders, in other words. The second reason to integrate is that on the other flip side of the coin, there are many patients who are seeing primary care providers who have mental health needs but aren't getting those mental health needs adequately met. Maybe they are actually addressing those mental health needs with their primary care physician, but their primary care physician has limited expertise and training in mental health issues. So consequently, they're not getting appropriate treatment. In the United States today, most people who are taking anti-anxiety medications and antidepressant medications are getting a medication prescribed by their primary care physician, and only a small minority are getting those prescriptions through a specialist, in this case a psychiatrist or maybe a psychiatric nurse practitioner who is providing specialized prescriptions for mental health needs and has training in that area. So in other words, neither environment, public mental health nor primary care, in and of themselves have the sufficient expertise to adequately treat the whole person. That's a way to think of it. Now, let's look at some health disparities here. Clients of public mental health services die on average 25 years younger than other Americans. Now, at first you might say, well, yeah, but that might be because of their mental health. I mean, you can't compare people who have mental disorders to people who don't have mental disorders and expect equal outcomes. But if you look at these next two bullet points, between 15 to 20 years of that disparity is attributable to heart and circulatory disorders, diabetes, and other chronic diseases. And by contrast, only 5 to 10 years of that disparity is attributed directly to the mental disorders, for example, by suicide. And now, of course, the big kicker here is that even the things that you see in that second bullet point, like heart and circulatory disorders, diabetes, and other chronic diseases, do have substantial connections to a person's mental health. But that, again, just all the more builds the case for the importance of having integrated care. Now, as counselors, part of our professional identity is we are trained to be very holistic. That is to assess a client through a biopsychosocial and perhaps spiritual model where we are assessing all domains of a person's being, looking at all areas of a person's functioning, and then determining what we can help out with as counselors versus what we might need to refer out to somebody else to do. And the CBT model, or the cognitive behavioral therapy model, I think does a great job of illustrating the complexities and the interactions between the mental health realm and the physical or medical realm. So what you see here in the CBT models, we start off on the outer layer here with this red outlining that symbolizes the environment. And that includes in ABC models like rational motor behavior therapy, activating events or adversities. In other words, situations or events or circumstances that will trigger emotional discomfort in the individual. So we go from the things that happen in our environment to cognition. Cognition is the way that our brain processes or makes sense of that stimuli coming from the environment. So our brain has to think a certain way about what happened around us to make sense of that information. So for example, if I lose my job, I may think to myself, I'm a loser, I can't do anything right, I'm hopeless. If that's the way that my brain processes things, then I'm likely to feel emotionally sad or down or depressed. Physiologically, I may notice difficulty concentrating, fatigue, irregularities in sleep-wake patterns, lower levels of energy or emotivation, and then behaviorally, I may withdraw and isolate. I may avoid, because after all, things are hopeless, might even avoid job search activities and that sort of thing. Now, if I do that, if I behave that way, that will reinforce my belief that I'm a worthless and valuable person, and it will probably have me feeling all the more depressed, which will probably all the more increase my physiological manifestation of depression. Now, conversely, in that same environmental trigger, job loss, I may be thinking to myself, oh my gosh, I'm not going to be able to get a new job. I'm going to fall behind on rent. I'm going to get kicked out of my apartment. I'm going to end up homeless on the streets where I will surely die of starvation. Then my emotional reaction might be anxiety or panic. I may get increased heart rate and respiration, butterflies in my stomach, a choking sensation or a tightness in my throat, extra bursts of energy and muscle tension, and then I may react by freaking out, yelling or screaming, by getting into an argument with supportive other who's just trying to help, or again, by running away from or avoiding things that are distressing that actually could be productive for me to be doing, like job search. And if I were to do that, that will all the more reinforce my belief that things are disastrous and dangerous and horrible things are going to happen, which will, of course, intensify my anxiety and so on. Now, if we take that same activating event in the environment, the job loss, and my cognition is, how dare they, after all I've done for them, to treat me like this? This is a grave injustice, and I need to get back at them. Then I could feel very angry or enraged and get some of those same physiological sensations as the flight response, like the increased heart rate and muscle tension and the extra energy and so forth, and maybe I go back to my workplace with a gun. So you can see how the same event in the environment will have very different outcomes for different people based on how their brain processes what happens around them. Now, in an ideal situation, I might lose that job and I might be thinking to myself, you know what, people lose jobs sometimes, not the end of the world. I've gotten plenty of jobs before. I've never had a problem getting a job. I'm sure I won't have a problem this time. I'm well qualified. I'm a perfectly capable person. I know that about myself. And I've got some money saved up so that I've got a safety net. And I might be feeling concerned and worried, but not overwhelmed. And then I might have a relatively normal physiological response. And then I might behave in very adaptive ways, like engaging in job search and connecting with people who I know who might know about job openings and beefing up my resume and going to LinkedIn or Monster.com or whatever and really pounding the pavement looking for my new job. Which should, if I did that, I'd be very likely to get a new job very quickly, which will change my environmental situation. And I'll think about how capable and competent I am and how relatively safe and predictable the world can be, and I'll feel good about myself. Now, how does this all impact the world of medical or physical well-being? Well, again, you see how our physiology can be impacted by our thoughts and our behaviors and our emotions, and these are the realms of counselors. Counselors do an awful lot in these areas. And so the way that people think and feel and behave about things has an impact on their medical well-being, their physiology, which will become all the more noticeable in our next slide, where I give you some information about the HPA axis, which is basically a circuitry or a system within the human body where our brain processes things as being threatening. Maybe the amygdala is sending some warning signals, and the hypothalamus is a regulation center in the brain. So it makes sense of these messages that other parts of the brain are conveying, and it signals to various glands to start releasing different chemicals. So the hypothalamus sends a message to the pituitary gland, which sends a message to the adrenal gland, which says, inject cortisol into the bloodstream, release cortisol. And when cortisol gets into the bloodstream, it activates the fight or flight response. And that's okay if it's a temporary acute stressor, like I'm driving down the road and somebody doesn't see me because I'm in their blind spot and they try merging into my lane, and I react with a sudden sense of panic and I honk my horn, and then they veer and correct their path and everybody's safe, and it takes a little while for my heart rate to come back to normal and for me to feel okay about things. That's not a bad thing. That's a good thing. That's a great thing. That's a wonderful thing. But if that stressor is, oh my gosh, there have been layoffs in my company and it's a time of economic recession, and is my job going to be next? Maybe not today, maybe not tomorrow, maybe not next month, but maybe 6 months from now I won't have a job. And if and now because we're downsizing, I have way too much work to do, and I come in every day and my inbox is full and I can't keep up, and this all seems hopeless, and I'm just barely dragging through to get from day to day to day, and I'm making tons of mistakes. Now I'm feeling chronically stressed. And when we're chronically stressed, that HPA axis that keeps that fight or flight response going is deferring or detracting resources away from the immune system. All that energy is being taken away from the immune system into the fight or flight response. And so consequently, I'm going to be more susceptible to infections, more likely to catch the common cold, for example, or the flu. And I'm going to be less able to recover once I do have some kind of an infection. And if I have some kind of chronic medical condition, I'm going to be more likely to have flare-ups or relapses or lapses, and less likely to be in remission. So there's an obvious connection between our emotional or mental well-being or health, mental health, and our non-mental physical health. And this, again, builds a case for the need for counselors to be involved in integrated care. So there are 4 models of care integration that you see in your text. The first model is integration of specialty services in a primary care program. So this is where you have a primary care physician's office, and maybe that primary care physician's office has a counselor in that office who is available to provide therapy or behavioral consultation or assessment for patients who seem to have mental health related concerns. So for example, I have a colleague who is a clinical social worker who provides counseling and psychotherapy, and she is an employee of Baycare, a large local healthcare conglomerate, and her office is in the primary care physician's office. So if he has a patient come in and they seem to have problems with stress and anxiety or depression, then he may or may not prescribe medication, but he may also be referring them to my friend to do counseling and to help the client out with cognitions and behaviors, changes in those areas to improve their overall health and well-being. So that would be an example of model number 1. Model number 2 is a consumer-directed medical home, which we will cover in a future slide, so we'll not talk about it now. Model number 3 is integrating primary care services into specialty programs. So an example in your text is Cherokee Health. Cherokee Health is a community mental health center. So they are a mental health specialty program. Patients go there because they want to be evaluated for mental health disorders and receive maybe psychiatric medication or counseling or psychotherapy, groups, and so forth. But at Cherokee Health, they have primary care physicians on staff. So if they do an assessment with somebody and they determine from their biopsychosocial assessment that this person is in need of an annual exam and maybe some blood work to rule out other organic medical causes or contributors to their disorders, then they may set the person up to see a primary care physician right there in the same office in the Community Mental Health Center program. So that is model number 3. We bring the primary care folks into the mental health center. Now, by the way, you see this with other specialties too. Like I have a friend who is a therapist, a counselor, who works in a neurologist's office. The neurologist works with people with multiple sclerosis who have a high co-occurring or comorbidity rate for depression and oftentimes have a lot of anxiety problems and and so forth. And the neurologist may set the patient up for a consultation with a counselor to look at whether or not it might be appropriate to do psychotherapy as well, so that we're treating the person more effectively by looking at the whole person. Model number 4 is a collaborative care model where you have separate programs that work together. Model number 4 is what I do in my practice. I work in a counseling practice. All we have working here is counselors, clinical social workers, and psychologists. We do testing and evaluation, and we do therapy, individual, group, and family or couples psychotherapy. Now, if we do our biopsychosocial assessment and we determine that, again, somebody may have some co-occurring medical problems that need to be addressed that can be contributing to their mental health, and or there could be some organic contributors to their mental health. Like, for example, they seem to have depression, but we might need to rule out whether or not they have a thyroid disorder that could be causing a lot of these heavy physical symptoms of depression, or at least making it worse. Then we will want to refer them to a primary care physician. So we have a network of primary care physicians who are out there. They're not employees of ours. They're not on our payroll, but we know they provide quality care. We get great feedback from patients about them, and they communicate well with us, and we share records back and forth. Client signs a release of information. We send an in-depth referral over to, or a detailed referral over to the primary care physician, and voila, the patient has their integrated care. So those are separate offices, separate providers that all are sort of collaborating together to provide integrated care to the patient. So that is a 4th model, which I am personally a big fan of. But of course, I am biased. So let's talk more about medical homes. The philosophy and concept of medical homes are that one, they're patient-centered, which means that all of the practitioners who are involved in the patient's care are working together to make sure that the care that they're providing is consistent with the patient's informed consent, so that the patient is appropriately educated and that the patient is making informed choices on their care. Second, they are comprehensive, so the idea is to cover the entire, all of the areas of need for the patient that are medical and mental health areas of need. They're coordinated and they are accessible. One of the big pushes with medical homes is to have electronic health records, and including patient portals, so that patients can sign into a portal and they can view their blood work and they can access their records, and also so that providers can easily send information back and forth between 2 different specialty centers. Say the neurologist beams over medical records to the mental health counselor and vice versa. So we can easily and quickly get information that will help us with treating the patient more effectively. And of course, there's a commitment to quality and safety. Now let's talk about accountable care organizations, or ACOs. In ACOs, there's a joint responsibility for the costs and outcomes of the patient's medical care. So by definition and by nature of an ACO, all of the different specialty providers, the counselor, the primary care physician, the neurologist, the dietitian, the massage therapist, whoever is a part of this accountable care organizations, they're all employed by the same ACO. So in other words, you are not self-employed. You are an employee of a healthcare conglomerate or a healthcare corporation or whatever else. And then you're all coordinating the patient's care, and you're all mutually accountable, but you're also accountable for controlling costs and providing efficient care using the resources that you have available to you. ACOs are strongly encouraged by the Affordable Care Act. So here's where we get into a critical thinking exercise. If I were doing this lecture live in class right now, I would ask you all what you see as being some of the benefits and drawbacks of integrated care. Because you've not only paid attention, hopefully, to this lecture, but you've also been required to read a lot of material on integrated care in your modules for this week. So hopefully you have a good idea. And usually in class, We'll talk about the benefits of integrated care. Personally, these are some of the benefits that I see. Number one, more communication between the different treating providers will usually mean more efficient and effective care. You know, it would be great, for example, for the primary care physician working with a patient who's prescribing them Xanax to know that the mental health counselor did a thorough evaluation and that the client is there because they have a chemical dependency or an addiction and their life is becoming unmanageable because of their Xanax use. So we might or improve communication between different medical entities. Second, you may find that some of the stigma attached to mental health treatment gets reduced, and that primary care specialists or health specialists who are working with the patient may, some of them, frankly, they think of mental health as being sort of a quasi medicine. They don't think of it as being real medical help or real health care. They think of it as being something else, where they think it's all in the patient's head and it's that simple. Or some are just uncomfortable having a discussion with patients about a referral to see a mental health specialist because they're afraid the patient will get offended and think that they're being accused of being crazy or being invalidated or something along those lines. So the more that mental health practitioners get integrated into the primary health specialty arenas or the primary health arenas, hopefully the less stigma and mystery that will be attached to mental health treatment and the more widely it will be accessed. Now, another benefit to integrated care connects also to the Affordable Care Act. The Affordable Care Act is a healthcare reform legislation that provides incentives for integrative care. Now, there are benefits and drawbacks to the Affordable Care Act, and we're going to talk about some of those as we talk about the benefits and drawbacks of integrated care, because there are relationships between the ACA or the Affordable Care Act and integrated care. Part of this is because the Affordable Care Act provides financial incentives for large conglomerates to provide all of integrated care under the same roof. So, in other words, more public funding will be available for for medical conglomerates that provide behavioral health care in-house. Now, some of the benefits that come along with the Affordable Care Act. Number one is that more people get insured. We've already seen the number of uninsured Americans decrease in the United States. So that is the first benefit. More people having insurance means more people can access their care, hopefully in affordable ways, which you would think would also be more business and more demand for counselors. A second benefit is that the Affordable Care Act has some provisions that enhance mental health parity. Mental health parity means that an insurance company treats mental health care on par with or equal to other types of health care. So the Affordable Care Act and mental health parity basically specifies that insurance companies must use must provide very similar parameters for mental health benefits as they do for non-mental healthcare benefits. So, for example, one thing I saw is that when the Affordable Care Act was passed, we saw less need for prior authorization for patients who want to get psychotherapy. Prior authorization means that you have to contact the insurance company, provide them with clinical information, and get permission to get a certain number of sessions authorized to work with the patient. Well, very rarely do I ever see prior authorizations being required for outpatient care anymore, because they don't require prior authorization for outpatient care for other medical specialties, so they can't just sort of discriminate against mental health in that way under parity. A third benefit is that if you have a patient who has pre-existing medical conditions, and those pre-existing medical conditions can include, let's say that a patient has schizophrenia, and they lose their job and they lose their healthcare insurance along with that. And now let's say they become self-employed. And so now they're going to buy their own healthcare insurance. It used to be that healthcare companies could refuse to sell them a policy because they have a pre-existing condition. Now, keep in mind that traditionally, historically, insurance was something that you paid for that you didn't expect to use. You were being insured against an unlikely event that, if it happened, would be too cost absorbent that you'll need coverage for it. Like, for example, life insurance. You don't think it's very likely that you'll be dying prematurely, but if you do, you're covered, right? But you hope to not collect. Insurance used to be the same way, even health insurance. It would be, look, if you develop a condition or you end up with a medical problem that you do not have now, you will be insured or covered against that. Well, nowadays, what we want, or what a lot of people seem to want, is they want insurance coverage no matter what, whether they have pre-existing conditions or not. And so insurance companies could refuse coverage for pre-existing conditions because it would be too expensive for them. They wouldn't make enough profit or whatever else. Well, now with the passage of the Affordable Care Act, insurance companies can no longer refuse coverage to people or refuse to sell people policies because of a pre-existing condition. However, one thing to pay attention to is that they can still charge an awful lot of money. So they can charge a higher premium if you have a pre-existing condition. They just can't deny you policy. So now let's look at some of the benefits or drawbacks both of the Affordable Care Act and of integrated care at large. One of the drawbacks for patients is that some patients are actually paying more for healthcare insurance than they used to prior to the passage of the Act. Some of them are losing their old policies because they aren't compliant with the new standards of the law, and they're losing their physicians because their physicians aren't on their new insurance panel. Now, this actually is why I think it was the Washington Times gave President Obama the Pinocchio of the Year award, or in other words, the Lie of the Year award, for his infamous claim that if you like your current plan, you get to keep it, and if you like your current doctor, you get to keep your current doctor. That did not pan out to be true. And I'm an example of one of those people. See, I used to buy an insurance premium for a mere $89 a month as a self-employed, relatively young American with no pre-existing conditions. In fact, just about 3 or 4 years ago, I only paid $89 a month. That's pretty cheap for an insurance plan, and it was a good plan, and it suited my needs very well. However, when the Affordable Care Act was passed, I was informed that my plan was now illegal under the law, and that I was not allowed to maintain it. And I asked, what's illegal about my plan? And they said, well, the Affordable Care Act requires that you have several benefits that you do not currently have. I asked, what are those benefits? And I was told things like, number one, you do not have maternity care. And so I said, of course, well, I'm a male, so I can't really have a baby. Don't need maternity care. And they said, it doesn't matter. You have to have it under the law. And another example was I didn't have emergency dental care for children. I said, I don't have any kids. Why do I need emergency dental care for imaginary children? And they said, doesn't matter. Have to have it under the Affordable Care Act. So it's adding all these bells and whistles that I don't need that cause my premium to go up. Well, the cheapest comparable plan that I could have had to what I had before the Affordable Care Act was $263 a month versus the $89 a month that I was paying. So as you can see, that didn't pan out well for me. And actually, that plan wasn't comparable because I had a $2,000 deductible prior to the Affordable Care Act, and the $263 a month plan had a $6,000 deductible, which would mean that I would have to pay the first $6,000 of my healthcare costs out of pocket over the year. So it was a terrible change. And I learned that if I paid $350 a month instead of $260 a month, then I could actually get my deductible down to zero. So I sprung for the $360 a month, and I used to only pay $89 a month. Well, year 2 of the Affordable Care Act came, and my premium went up to $400 a month. Year 3, I am now up to $500 a month for the same plan. And I used to just years ago pay $89 a month for good insurance. So I'm in that bracket of Americans, self-employed, buy your own insurance, don't have pre-existing conditions, you don't use a whole lot of healthcare resources, but you pay a lot more because the act requires you to have things that you don't think you need. So the act works against the ability of some patients or consumers to be able to get tailored premiums that fit their needs more adequately. Now you could argue that by me paying more, other people get to pay less in my pool of insurance consumers, and that maybe that's beneficial, but other people view that as very damaging to them. Now, even some of the people that the law protects in many cases, because a lot of people get good deals with the Affordable Care Act, they get subsidies to get cheaper and more affordable insurance that they couldn't have afforded before. So they might get a really good deal. But even some of the people that the law is intended to help, like people with pre-existing conditions, in some rare cases lose out. My mother's a great example. She had a plan with United Health, and that insurance plan was a charitable plan designed for people with pre-existing conditions that gave them a discount. But when the Affordable Care Act was passed, many of the insurance companies got rid of those plans because, again, they weren't compliant with the law. And so she ended up without insurance for 6 months, and the cheapest plan that she could get was way out of her price range. And she is a stroke victim, and she has lots of medical conditions and concerns. It was a really bad experience. Fortunately, eventually she was determined eligible for disability, and then she got Medicare anyway. But for quite a while, she was uninsured because of the Affordable Care Act, and in fact, then had a penalty to pay on top of it all because you get penalized for not having insurance under the Affordable Care Act. So another drawback for counselors specifically is that the projections are that there will be a reduction in the private practice market. Again, think of it sort of like this. Imagine that the government used taxpayer dollars to give more money to Home Depot so they could expand where they do, and that would be give them a competitive edge over the small mom and pop hardware stores which now go out of business. And your public dollars were used to make that happen. Some people look at the Affordable Care Act that way because tax dollars are going to large healthcare conglomerates to provide the behavioral health care in-house by people who are employed by that conglomerate, so there's less work available for the private practitioners who can't compete. And if you're going to go work for a conglomerate and be their employee, you're going to probably make less money, or you might make a lot less money, and you're going to have more limitations in the number of sessions that you can provide, and maybe even limitations on the types of therapies that you provide, or the specialty populations that you provide care for. And your business practices, of course, you lose power over that because the conglomerate now makes those decisions, and many of those are administrators who aren't clinicians, and they may make choices that you do not think are good, sound clinical choices, or that negatively impact quality of clinical care. So that's a potential drawback. And so what we sort of see is an expansion in counselors working for companies instead of being self-employed. So keep in mind, anytime there's an action, there's a reaction. One unintended consequence, I'll give you a great case example. After the Affordable Care Act was passed, I suddenly got an increase in referrals through an EAP or Employee Assistance Program of a large local healthcare conglomerate. Actually, it's a national healthcare company. And their employees were starting to come to me through EAP, and I'm like, why am I getting all these healthcare practitioners all of a sudden? Well, to give you an example, there was a nurse practitioner who came in and talked to me, and he said, with the passage of the Affordable Care Act, the ER started, the emergency room in started implementing some changes that are well-intentioned, but they don't necessarily help with good clinical care. Specifically, he said, in our ER, we have a lot of opiate addicts who come in and they complain about some kind of physical discomfort, but they're med-seeking. They're just looking for more opiates. And this is inevitably going to make things worse for them. So he said, what I would like to do in a case like this is spend time with the patient, assessing and really teasing out, is this legitimate medical need or is this med-seeking? And if I determine that they appear to have an addictive disorder, to refer them to appropriate providers and to coach them on alternatives to the opioid medication. He said, but with the passage of the Affordable Care Act, and this is true, there are tax incentives or public funding incentives for ERs to A, reduce wait time in the ER, and B, improve patient satisfaction. Well, at first, this sounds great. You want people to spend less time in the ER waiting, and you want them to be satisfied when they leave and to say so in a survey, a patient survey, right? Nothing wrong with that. But what happens when you try to spend a lot of time with the opioid-seeking individual with a chemical dependency, and you send them away when they're med-seeking opiates and you don't give them their opiates? Well, you increase wait time because you're spending more time with the patients that you work with, and B, you are decreasing patient satisfaction because that opiate addict is probably not going to be very happy with the service you provided because you didn't give them what they wanted. So he said, we're being pressured to just give them what they want, give them opiates and stop spending so much time assessing and consulting and referring, and just send them away happy and quickly. So these are unintended consequences, and there are always going to be unintended consequences. And it's up to you to decide whether you think the benefits outweigh the drawbacks or the drawbacks outweigh the benefits. Now, right now, we're in a point of uncertainty with healthcare reform because, as you know, President Trump got elected, and one of his platforms is to repeal and replace the Affordable Care Act. So we don't really know what's going to happen. Whatever happens, my guess is there will be some benefits to it, but there will also be a cost with some drawbacks to it. And I think it is critical that counselors be educated on the possible benefits and drawbacks, and that we start to look at ways to compensate for those drawbacks going forward. And that will be another emerging issue in our industry for you to grapple with. And we will be here, counselor educators, researchers, and your professional associations to help you with that. So that's about all I want to say for integrated care today, and I will look forward to seeing you all next class.